so nice to see so many familiar faces in the room, like former fellows, former co-residents, friends from undergrad, like all the way back, and former attending. So it's nice to be here. This is going to be quite casual, so feel free to interrupt at any time. I don't have any disclosures to have, except that I have a personal interest in this because my family, as many of you know, came to Canada as refugees, and I now work in the shelter that actually supported my parents when they came to Canada as refugees. So like very full circle moment. I thought today, some of you, did anyone hear the grand rounds on July 17th? Yes. So this is going to be more focused for your work. That was very general and really focused on policy trends. You might see some things being reminding us back to that, but this is going to be focused more on what I think you see. And also I want to have some time to kind of zone in further on what is it that you actually want to do and achieve for the kids who are being impacted by migration in your practice. And so I'll share some approaches that I have used and have been taught to me by my attending, some of whom are in this room, and also have you know about some strategies that work here locally to advocate for migrant children. And then I wanted to briefly toss in, because I am a clinician scientist, I do use participatory methods to co-design interventions with families, even families of children who have disabilities. And I wanted to throw that nugget out there that I am here as a methodologist. I am here to work with you. So sharing an example of how you can do that to build interventions. And if people want to scaffold on that and work together to do that for children with developmental needs here in BC, hit me up. So why are we talking about this? As you know, I shared this slide in July. I just wanted to highlight that this is every 2 years, the UNHCR puts out this report on the migration status of migration, and every 2 years it's worse. And so now they say really 1 in every 70 people, or 1% of the entire world's population, is displaced. 114 million people are forcibly displaced, and of those, 41 people are refugees, 9 million are asylum seekers, and children are overrepresented. Children are almost 50%, so under 19. But when we look at children who have disabilities, we actually don't know the data on how many displaced children also have disabilities. But we do know that a huge number of children around the world, displaced or not, have disabilities. We know that they are more likely to not get medical care. They're more likely to not get educational services. They're more likely to live in poverty. They're more likely to have actually never attended school. And they're more likely to also, be discriminated against globally. So this is just the backdrop. But when you try to dig further, there's very limited research. We actually don't know globally what that looks like. So there's another opportunity, even in our population that we're seeing come to Canada for resettlement, to start to extrapolate backwards maybe and get a sense. But I wanted to just ask, straw poll in the room, safe space, no judgment. How would you all describe care for immigrant and refugee children with disabilities in BC right now? Like a word, an emoji. Fractured. Barriers. And from your experiences, how would you describe it?
It's just not great.
Not great. Okay. Any other thoughts? Your experiences? Complicated. For context, I've been working here full-time since July 1st, so really want to know what your thoughts are, having probably been here a little bit longer.
Really do get to the right
door. So if you're lucky enough to get to the right door, it can really open things. But it seems, what I'm hearing in that, Angie, it's luck of the draw if you happen to get to the right door. Why do you think this is the way it is right now in BC? Honestly, just spitballing together.
I think part of it is that people that are making decisions don't recognize how big of a problem this stuff is. Because if certain patients get to the right doors, they can get access to certain kinds of services, but they don't realize the gaps
to get to the right door.
To get to the right door, but also once you get to the right door, to go back and have ongoing community care, they don't recognize what is missing.
I'm just going to repeat so that folks online can hear, is that Mandeep was saying that like if the folks who are making the decisions have no idea what's happening on the ground, and also because sometimes they see the people who get to the right door, they're like, oh, everything is fine, but they don't actually look back and see what that looked like on the ground. That's very helpful. Any other reflections on like why it is? Yes, Emily.
Just very complicated.
Complicated. Tell me, what do you mean by that?
There's a lot of people involved. There's a lot of there's politics, there's healthcare, there's people on the ground, there's the people that make the decisions. Like it's actually difficult for everyone to connect and make a plan.
So it's
more so than for able-bodied people.
For able-bodied people. And what about people with disabilities who are not immigrants or refugees? How does care for when you don't have that intersection of migration and disability? What would you say care is like? Is it better? I mean, my guess is it's still fractured and still not great, but maybe incrementally better. And why do you think that is incrementally better?
I think some of the cultural linguistic barriers.
Cultural linguistic barriers?
Perhaps still there, but less likely.
Less likely, okay, yeah. Any other reflections?
Even when you're thinking, it's so layered, because even when you're thinking of when you're coming into a system versus already being in the system, when you're coming into a system, having all the linguistic barriers, but then also having the support people on the ground who don't necessarily have knowledge or the tools to identify that a child has a significant health barrier. So it's not just upper, it's also how do we support the folks who are supporting these folks.
And remind me your name.
My name's Shazeen.
Oh, we emailed. We're going to talk later. Hello, so nice to meet you in person. And we have a mutual patient that we're taking care of that I think highlights a lot of these cases. So Shanti, I'm just going to synthesize what you said for the benefits of folks online, is that Shanti was saying that it's also not just about working with the family, but for newcomer families, it's the support people around them who also don't know what they need, what the services they need, how, and may not even be recognizing that this child has needs. And certainly I work with settlement organizations across the country. And I had one of them who I work really closely with being like, so if they're having behavior problems, do you think we can send them to pediatrics? And I was like, yes, please do that. Please get them to see their pediatrician. But they never connected that might have been a reason to help connect that child to care. And I think that's just a very small example of one of the, how do you get to the right door, right? Like what Angie was saying. So I wanted to put that in our minds because what I'm hoping is as we talk through some of just clarifying the very murkiness that's out there, we can start to think about where are the opportunities to maybe make it a little bit less fractured and maybe make it a little bit less up to chance that you get to the right door, right? So what can we do as a group? And I shared this slide in July, but again, I put this up because I just want to highlight for you how immigration status in Canada is a determinant of health. It does not have to be if we made different rules. But the way we've set it up now means that what your immigration status certainly dictates what kind of care you got before, whether you got any pre-arrival screening, whether you get any formal settlement support, which is financial from the government or officially get assigned a settlement worker, and whether you get access to provincial health insurance and benefits. And I will say BC is better in some respects in terms of who can actually access MSP compared to other provinces, and worse in other respects. So, nothing is perfect. But what you see mostly in Vancouver are people who come as economic immigrants, which is they've got a lottery, they got a PR, they're coming here to work, or they're being reunified with family members who have PR here. So those folks do have access to MSP. They get some element of screening before they come here, but we often don't have access to it.
Oh, and try sharing one more time.
The slides went away?
Yeah.
Okay, sorry, I didn't touch anything. Can everyone see my slides now?
I'll just check.
Okay, sorry.
They can hear you.
They can hear me, great. And so the key though is these families don't have any formal access to settlement support, right? And so they're sort of left to navigate with their own family networks and supports. If you're a resettled refugee, and this means you've come through the government program as a government-sponsored refugee, or something called a group of five, which would be 5 individuals pool together the resources to support a refugee family for a year, or something called a settlement agreement holder, which is instead of people pooling their resources, an agency, so it might be a church or a faith group, puts up the funds. These individuals come as as permanent residents. So again, they've both gone through the same process with the government. They get some element of screening. Government-sponsored, government-assisted refugees get funding directly from the federal government for a year. Privately sponsored refugees get support from their private sponsors for a year, and they are eligible to apply for MSP if someone helps them do that. So a lot of the times people don't even know that they have to actually register them for MSP. But there is some data that shows that privately sponsored refugees do better than government-sponsored refugees, because the drop-off point is at month 12. They have support until month 12, and they're like, okay, bye, you are settled, go forth. And we all know that that's not true, but privately sponsored groups tend to, their sponsors are invested, right? And so they do tend to provide more emotional support, even if the financial support is not there after the 12-month period. And that does seem to reflect better in how integrated families are. Is it still doing the same thing?
It's good.
Okay. And then if you're an asylum seeker, now these are people who have come to Canada by some way, and are, now that they've come to Canada, they are requesting asylum, which means they need their case to be adjudicated on. If you're a resettled refugee, this has already been done by some international body, the UN High Commissioner for Refugees or the Red Cross. If you're a refugee claimant, it does not mean that your claim is not as valid. We know that almost 80% of people who file asylum claims are found to have valid claims in a court of law. It just means you haven't been able to get in front of one of those international bodies, so you got to Canada by some way, and now that you're here, you're requesting that. And you're then in this temporary period between when you made your claim and when you're seen in that court of law. And then in Canada, we have something called the Interim Federal Health Program that provides coverage for these individuals during that time. But the settlement support for asylum seekers is very, very limited, as is any pre-screening, because they might have just come here without any, like I've had a family, one of my patients in Toronto walked from Brazil to Toronto on foot, and like through buses, through the Darien Gap, somehow made it through America. So, they can come any which way, and they may not have had any kind of care before. That child had many, many parasites and also had a developmental delay, but is doing super great now. And so I want to share this with you because this doesn't have to be the way. When I worked in the United States in California, every child had access to health insurance, independent of immigration status, the same Medicaid health insurance. And so it was actually easier for me to provide care for immigrant children in California than it ever was in Canada, which was very sobering. And I think, I see Dr. Farber here like nodding, right? Like sometimes there's actually some really great things that are in the US that we forget, but it doesn't have to be the way we've always done it. And that's the one nugget I want to put in your mind as we go through. And then lastly, there are people here on temporary visas. This is a bit variable. If you have a work permit and you're an asylum seeker, you may be eligible for MSP. If you're here on a visitor visa, you're not. If you're an international student, you have to get MSP, but you have to pay $75 a month. This is not uniform across the country in different provinces. So this is very BC specific. In other provinces, if you're in this category, you get nothing. In Ontario, you generally get nothing, even if you have a work permit as an asylum seeker. So I want to, for those, certainly if you're seeing trainees or you're moving across the country, it is highly variable. And this is just a summary to highlight again how your immigration status is a determinant of health, looking at your access to insurance, your access to the Canada Child Benefit, which is tied to parental immigration status, not child. So when you have a child who is a Canadian citizen born in Canada, they cannot get the Canada Child Benefit because it's tied to their parent, which I think is actually against the rights of children and a really fantastic opportunity to do some advocacy. And in BC, a really low-hanging fruit of advocacy is they tie MSP to parental status. So this is one of the only provinces where a child who is born here and as their family is living here, if their parent doesn't have MSP, they will not automatically give that child MSP. There have been studies that have shown that this was a wrong decision, which is why Ontario reversed it. But I think this is an opportune time to also make that change here. And then again, you can see their resettlement support is is very limited. So I'm spending time here because I just want to make sure we all understand that. I am not going to spend as much time on IFHP. I put it in my slides. It is in my recording from July 17th as well for details, but I do want people to know that IFHP is meant to be a temporizing federal insurance program for people until they are eligible for provincial insurance. I had a good call with IRCC on Monday where I said, I'm finding that a lot of people are not registering families who are eligible for MSP and full MSP, including Fair Pharmacare, because they say, oh, but they have IFHP, they don't need pharmacare. They're like, no, IFHP is temporizing only until they're eligible. If they're eligible at that time, make them enroll in everything. And so that's why for people who are asylum seekers, again, it's temporary until their claim has been adjudicated on, and then they get access to provincial benefits. And I want us to remember that, because then sometimes what happens is we're like, well, you have IFHP, we don't need to worry about these other programs, when we should actually be thinking the opposite way, that as soon as you're eligible for everything else, let's get you off IFHP onto other things. It does cover a number of services. I've been able to get all of these things from IFHP, but as you probably heard me say for the last few months, they call these supplementary benefits, but I would argue feeding tubes and oxygen and like a CPAP machine is actually kind of essential. But despite that, they have put co-payments on all of these supplemental services as of May 1st, which means someone has to upfront put money. And we heard earlier that there's a disconnect, right, between the policymakers. And so I'll share this little tidbit from this conversation I had with IRCC, which is Immigration, Refugee, and Citizenship Canada. They're like, well, for the co-pays, like the families should just be putting $50 a month away. And so then they have a little slush fund. And I was like, I have no words. Like you're saying a family who has come as a refugee, who has no literacy skills, who does not know any English, should be on their meager income of about $2,000 a month, should be putting away $50 a month just in case they need to pay for co-pays for that year. Like, talk about a disconnect, right? And these are people who don't actually have that lived experience. There's another policy change. So the Safe Third Country, did folks hear about this when I talked about in July? Just as a reminder. So basically, we used to say that if you entered Canada through a non-official port, you could claim asylum because before it said that you had to, only if you entered Canada from the US through an official port, you would not be eligible, but we sealed the border effectively to make it more difficult for people to claim asylum in Canada. And we have also made some changes. This was called our Strengthening Our Borders Act in response to some demands from certain administrations regarding our economic position. And so this is making it more difficult for people to file asylum here. But this is impacting a lot of people. I shared the story of one of our family supports students from Afghanistan. We have a student who was here before Kabul fell, then Kabul fell, and their parents had to flee. They got very distraught, understandably, and so they could not continue studying. And we worked with some lawyers to make file an asylum claim. But because it happened a year after she came as a student, they said her refugee claim is not valid. But they also don't deport families. They don't deport single young women back to Afghanistan. So she is now left in this limbo period. And so again, I think this is highlighting that children, they've started to unwind it a little bit. They were like, oh yeah, what about unaccompanied children? We probably shouldn't do this to them. So there's opportunities to do some advocacy to the policymakers to bring these stories to their attention, to say, oh gosh, wow, we had no idea this was happening. We're like, yes, because you're not the ones talking to the families. And again, hopefully inspiring all of you to sort of recognize that your word actually carries a lot of weight. And so again, what's the impact? This is going to cause more delays, more barriers to care. We may actually see more medical inadmissibility. Does everyone know what that is? So that when people are applying for permanent residency, the Canadian government will say, are you going to effectively say, are you going to be a drain on the medical system? And they can use your medical conditions to deny permanent residency. They used to characterize it by a certain amount. It was very low. It was like, are you going to use more than $9,000 in the healthcare system? They did increase it in 2016 to be closer to $100,000 lifetime. But all of us in this room know that for many of the children we serve, that's nothing. And so I raise this because this is also important for you to be aware of when families are asking for letters of support, how to frame things, who's their legal representation, what's the best way to support this family. Doesn't mean don't write letters. It just means being aware of all the nuance that needs to be taken into account. I think we're going to see people become more precarious status, which means have like this limbo status where they don't know what they're eligible for. Those folks tend to avoid coming into care because they're more scared, but we might see people come in more sick. And it also places young people, particularly with disabilities, at higher risk for exploitation and vulnerability. So what a great time to be alive in Canada and be a practitioner, right? So I think Sharon, you might remember, I've shared this story a little bit before. This was my very first patient. I think like I had just finished my training. I was 2 months into practice. I was working, of course, the holiday period because that's what they do to the new grads, right? And this patient came into my clinic. They were from Sudan. They had been in the US, but then came into Canada when at that time there was an administrative change that put their family at risk. This child had been here for 3 weeks, didn't have any provincial health insurance, was in a wheelchair, was G-tube dependent that had been placed in the US under something called CHIP. So they had gotten a lot of care in the US when they first arrived, but now they were down to their last can of formula. They went to the children's hospital near where I worked. The children's hospital emerge was like, I don't know, but we know this one doctor in this other hospital, go see her. And so, because they didn't know what to do when this family didn't have provincial health insurance. So it was the holiday period, 1 can of formula left, and a child with CP, G-tube fed. And how many folks are feeling anxious and frustrated hearing that story right now? Some nodding, right? That's okay. That's how I felt too. But just hold that in our minds, right? And so one thing, and I'm sure all of you know this and experience this all the time, that many people who have come here from other countries, it's not that some of them may have never experienced healthcare, or that healthcare was a place you only went to die, right? You were only going to the hospital in dire straits because it cost too much money. But other people have had really excellent access to care, but the care looks different. And again, when I was living in the US, it was very different for me. When I learned I did not have to have a referral for certain specialists. And other families, when they come here, are coming from similar systems. So the words referral, the word resident, the word consult, the word services, that doesn't mean anything to them, but it means stuff to us because that's what we speak all the time. So there's a cartoon series called Strange Planet, which is as if little aliens came to Earth and were looking at what we did. So, they talk about flossing as like rubbing string between your mouth stones and eating waffles as sweet discs, right? And I think about that because I think sometimes what we say in medicine is like being on a strange planet. And so we just need to really think how we explain every step we do in a very basic way with as little jargon as possible. So I will explain a referral by saying, so in Canada, if I think you need to see a doctor with more expertise than me in this area, I have to write a request to them to ask them to see you. I don't have any control over their schedule, but I can make the request. I can ask as much as possible. And if they think that they can help you, they will call you and tell you when you can see them. That's how I explain referrals. If I have to explain a prescription, I'll say, here's a piece of paper. You're going to go downstairs. Did you see that store that had all the medications in it, the pharmacy? When you go to the pharmacy, you're going to look for a counter at the back where someone is standing. You're going to give them this paper. They will look at the paper and they might ask you for this other paper that you have. Can you show me your paper? So I'm asking them to show me their MSP card or their IP card. Give both of those to the person standing behind the counter, and then they will give you the medicine. If they don't tell you how to take the medicine, I might write a letter saying, like, please use an interpreter to explain how to take the medication, or please put instructions in this language, on the pill bottle. That's, again, how I explain how to take a prescription, because prescriptions don't exist in many parts of the world. And so this is how you develop trust with families who have a lot of mistrust, right? I think, Shanti, you can say the family that we have, it has been such a testament to the care teams that this family has done a complete 180 in terms of how much they trust providers. Because this is a family 3 days after coming to Canada, the child needed to be admitted to hospital and the family was initially refusing to go. And when came in, has been now admitted for almost 2 months. And now this parent, actually, I saw going to see another refugee parent on the same floor and providing support. So it was because in her mind, like, hospitals were death, hospitals were scary places, something was going to happen to her child that they had never expected to live this long. So seeing the same people, seeing people be kind, I brought samosas and biryani to the family, and I made sure they got halal food. And those little things made a big difference to this family. And then you have to validate. So some people say, oh, I thought the Canadian system would be better. And it's sometimes tempting to be like, well, it's not bad. I'm like, no, you're right. It sucks, right? Sometimes you just have to be like, you are right. I wish it was better. I wish we could get that doctor to make an appointment for you sooner. I'm so sorry that that's happening to you. But helping people validate that frustration is really important. A lot of the time with children with disabilities, it is managing their expectations and our expectations, right? I like solving. I love being able to say, oh, I know what this is, right? But that's not sometimes what the family wants or cares about. Earlier, I had shared a story about a patient of mine who is 18 who had come to Canada last year in September. I saw them for the first time in June, and this child is paralyzed from the waist down, had seen a couple other doctors before me, but had never seen a doctor. Had been paralyzed from the waist down for over a decade. And I asked them, I said, what do you want? They said, well, we want to see the best doctors. We want to know why this happened. And we want her to walk. So I was like, okay, now I know what their priority is. I said, okay, in order for us to know why, we have to do something called an MRI, which means you'll have to lie down. It'll be very loud. And then they were like, okay, we'll come whenever it is, right? So they came for their 7:30 appointment. And then I'm like, I'm going to ask the best doctors to see you. I don't know why. We might not know why. And I don't know if we're going to be able to get you to walk, but I promise you I will try, right? Or if I have a family who the child very obviously has autism. I had a family in Toronto from Cameroon. The mother already had a daughter with a disability, with Charge syndrome. And the younger son now was very likely to have autism. And I asked her, I said, what do you hope? She's like, I just want him to talk. I said, okay, so here's what we should do if we want him to talk. Let's make sure his hearing is okay. And then would you be okay seeing someone to help him with his talking? Speech therapy, right? This is my nugget to get in. And let's see what happens for the next few months. Let's try and get him all the help he needs. And so for 3 months, we did speech therapy. We got a hearing test done. We were in daycare. And 3 months later, I said, what do you think now? And she said, well, what are you worried about, Dr. Suleman? I said, I'm still worried about the same thing I told you about. And she's like, okay, I see that now, right? And so it just took time, right? And this was a family I already had a lot of trust with because I had supported their other child. But even with that, I had to break apart that diagnosis. So setting priorities, doing it over multiple visits, focusing on their individual goals and figuring out who can help them with that. And communication barriers, it's more than just language, right? It's also literacy. So there are some languages that we see that are only oral. Many of the families we see have very low literacy, even in the language that they speak. And with literacy comes low numeracy, comes low problem solving, right? Comes low, critical thinking. All of the educational cognitive skills come along with that. And so that we just have to recognize that when we're talking to families. And yet these families are incredibly resilient. They got here. Like, they are navigating life here despite all those barriers. They are very, very strong. And so working with them to figure out their strengths, again, on their priorities, what's important to them, transportation barriers, it's sometimes not as simple as just giving a taxi voucher, because they still have to pick up that phone and call the taxi. So maybe it is the medical student who's with you. You say, you're going to walk them to the taxi phone, you're going to pick up the phone, and you're going to show them what you're doing, right? And you're going to make sure they get in the car, because families learn really quickly by also seeing that modeled for them. And it's a really great way to use your team in different strategies. And primary care is a huge issue here, as we know. And there are places accepting patients. And I don't have an answer for this, but my pie in the sky dream is that all providers know that there is a free provincial interpretation line that any person can use. It shocks me that not everybody knows that. That is such a gift in this province. This does not exist in other provinces. And it's a wonderful research project for folks who want to combine advocacy and policy to figure out how to better improve that uptake. I would say a lot of the folks you see have probably never had any vision, hearing, or dental screening. And so thinking about that, even if they're 18 for the first time and they're coming to see you, don't forget to do all those extra pieces as well. I know that you're the experts here, and I share this because I do want to highlight that developmental delay is common in refugee children. As I said, prevalence is hard to estimate. We think it's about 40%. We recommend universal screening. And when you're doing education back to the general practitioners who are referring to you, this might be something to kind of share back as nuggets that, you can do screening, and there are free tools that are validated that exist. My interest is also nutrition, and nutrition and development often go together. You will see a lot of children with stunting, and because of poor nutrition in the first 1,000 days of life, and we know that that's irreversible, but we also know that impacts their developing brain, right? So thinking about the two together. And so these are two tools that I often share with people. The Look-See, I used to love when it was free in Ontario. It's developed in Canada. It used to be called a Nipissing. It is in 10 languages. It can be used by anybody. So even the settlement worker that's with them, it's not free anymore. I don't know why, but the Survey of Wellbeing in Children and Youth is free. It's available in 31 languages. It's a little bit longer and a little bit more complicated to score, but it still can be done by any of their support teams. But for when I'm working with settlement agencies, I often would train the settlement workers on the Nipissing and say, when you're with the family, if any of them are scoring this, call me, let's get them in, right? And this is, again, to Angie, your point of how do you make sure more people are getting into the right door? You can do some of this education back out to your general practitioner colleagues. I'm sure this is something that you also see, that because they've had such limited access to services in the past, we are so used to saying, please send us all your records, please send us all of your formal testing. And these kids don't have it. And so again, is there a way we can be more flexible in our referral pathways? Is there potentially a checkbox we can put on our referral form that indicates to the lovely people doing our triage that you can still see this referral even if they don't have all their things attached, because they've never been in Canada, so they don't automatically get rejected and someone has to call back and try to get them in, and that even if they do have records, it may be mislabeled, not translated well. Genetic testing can be very useful. Some people are very afraid to explore genetic testing. And Shanti, I'm going to use our case example. So this young child has very likely a rare genetic disorder. And initially the geneticist said, oh, it's not covered by MSP, so we can't do it. And I said, hang on, this child also has IFHP. They're like, well, I don't know how to get it done. I'm like, well, I do. So I just emailed the director of IFHP saying, can I get your written permission that this testing that's done at Sick Kids will be allowed for us here? She was like, sure, no problem. And so within 3 days, they gave approval. We sent the specimen off, right? So when in doubt, ask. IFHP is actually, for children who do have IFHP, it's implemented through Medibee Blue Cross. They are very nice people. They want to help. So if you call them and say, here's the problem, can I get some coverage for this? What do I need? They will tell you, write me a letter with this, 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 and this. When do you need it by? Send it to this number. Okay, call me back tomorrow, right? Like they're very, very helpful. I also know that sometimes we have to tread slowly with accessing support. You know, we are often here, let's get you this device, let's get you into this therapy, right? But they may have never used this before. They don't even know what it means. And when I was in California, I asked my peds residents, I'm like, so can you tell me what a family does in speech therapy? They're like, I'm like, okay, so if a parent asks you when you're referring them to speech therapy and they say, well, what are they going to do? Can you tell them? And they couldn't, right? And I think I don't think that's unusual. I think a lot of pediatricians couldn't actually tell you what happens in ABA, what happens in OT, what happens in PT. So are there opportunities to do some more education so that we can also better inform parents of what is this person actually going to do, right? What is this device actually going to help you with? There is a lot of stigma, right? And so recognizing that families may not want that device, even if it will help them. And I think you let them be in control for when they are ready. And you can reassure them about if they share with you, well, you know, people are going to treat her differently because she's in a wheelchair. You say, well, tell me why you're worried about that. What have you seen before? And actually, you know, what's really wonderful here in Canada is, and tell them a little bit more, right? Transportation is quite a challenge, as you know, but also home accessibility. Many of the resettled refugees who are, they get placed in whatever home is available. So again, to our case, right? This child has fractures everywhere. This child is likely osteogenesis imperfecta. The femurs looked like horseshoes when they came in with multiple fractures. The child is elementary school aged and weighs less than my 16-month-old daughter. And the settlement worker was like, well, they can't stay in the shelter more than 21 days. We need to get them into housing. And so we were like, okay, can we just make sure the housing has no stairs? And because we were able to connect with the settlement teams right away, they were able to do that. But again, did they get to the right door at the right time? If they hadn't had our teams involved, it's very likely it would have been quite different. Some of these benefits, like I told you, are PT, OT, and SLP are supplementary benefits under IFHP, but subject to a copay. But I have a positive story on that at the end of the presentation. So in the last 10 minutes, because I want to make sure we have some time for chatting, what are things you can do? You can do trauma-informed care, right? From start to finish. Maybe break up what you normally do in one visit into like one or multiple visits. Try and have continuity. Focus on the family's goals. It doesn't have to be a perfect assessment, right? And I tell this to residents all the time. If you know that child is absolutely going to score on the ADOS and you can't get through the whole ADOS, give them the diagnosis. One thing to think about is that sometimes we have restrictive cutoffs based on age, but for families who have recently come and have never had care before and are presenting for the first time at 14 or 15, that may not be fair. And so is there something we can think through to how do we get these kids who have never had care before, how do we get them into the right door? And maybe these are cases you normally were like, we wouldn't bring them to BC Children's, but maybe because of trust, maybe because of language access, maybe because of social work support that doesn't exist, maybe that's a reason we would see this case here. And so I know I'm asking some big requests, but I put this out there hoping that we can start to think about things that we can do. And I know your division is a bit like preaching to the choir because you do this already, but is there things that we can advocate for other divisions to maybe think about this? Things to document. So, it is important for you to accurately document immigration status because, like I told you, it does dictate what things they're eligible for and making sure families get to the right door. I love that framing, Angie, so I keep saying it. But, if you think a person is a refugee, but they're actually an asylum seeker and you try to get them MSP and they don't get it, not only is that disheartening to you, but it erodes trust with that family because they put a lot, they said, well, you said you were going to get me this and you didn't. And so that status is important to clarify. It's also important to write down their language and literacy. It is so important in your note to write down settlement supports. Get the phone number for their caseworker. They all know who their settlement worker is, even if they don't know the name. Be like, show me on your phone the number, record it. That is going to be your lifeline with getting coordination for them. Document what kind of health insurance they had and find out what their school district is, because I'll show you not all school districts are equal in BC. And this is just a little approach that I use when I'm thinking about how to center the patient's circumstances in my plan. Like, is this service covered? Is it covered? I don't know. You can check the grid or just call me. How are they going to access the service? Where will they be able to communicate? Does this clinic use interpretation? Does this clinic refuse to use interpretation? And who's in their circle of care that needs to be included to kind of bring them along to these appointments? What is important to that family? That's what I'm focusing on. Try and identify people who accept the Interim Federal Health Program as insurance. You can make a list. If you're not, you have to register with every single place you work. So I am registered in Ontario, and I'm currently waiting for my registration to go through in BC. It's like a backlog right now. All new graduating trainees, tell them to register, and try to get them to be your friend. This is an example of letters you can give to your patients who do have IFHP, so that they don't get billed for services that are actually covered. We made these tools with a youth advisory group, youth who were refugee claimants in Toronto, and it's a toolkit available on my lab website. You can download and freely use. So we just fill this out, give this to the parent, and say, anytime you go anywhere, just give this to them first so that they don't get charged. I said this in July, and I'm going to say this again. Immigration status is information protected by HIPAA. There is no reason that if you find out someone does not have status in the Emerge or in your clinic, that you should be calling border services. I thought that was super obvious, but yet it happens hundreds of times in Metro Vancouver from hospitals. So I was shocked because even the hospitals I worked in the US would never do that and are actively fighting to keep hospitals as safe spaces from immigration. And so if you even find a colleague thinks they're doing the right thing by being like, oh, I found out they were undocumented, so I let border services, I actually would call a college complaint on that person, because that is violating our code of ethics and violating HIPAA. There's no reason to do that. So I just want to put that education out there. As I said, if you are seeing impacts of people unable to pay that 30% copay, please think about some of these strategies that have come through the Canadian Pediatric Society, and also share those stories. We are collecting stories across the country. You can either email them to me, but you can also just email as many stories as you like here, because they actually matter. So literally 5 days ago, the Carney government reversed copays on feeding tubes, on oxygen, on suction catheters, on cochlear implants, on nursing care, and PT, SLP, and OT in hospital. And it sounds really small, but it was because those things were, this is a patient of the Compass Clinic in Toronto, which is my clinic there. But I met and told many MPs about stories of kids eating feeding tubes and oxygen, and showed them the cost of copays for those children would be $500 a month, and told them that feeding and oxygen are not supplementary. They took my case a little literally because they only reversed it on feeding tubes and oxygen. But what it tells me is that they are listening. And we actually heard directly from someone in the Liberal Physician Caucus that it was the advocacy of physicians that actually opened up the Prime Minister's eyes to the impact of these cuts. So what you are seeing really, really, really does matter, because again, we heard that it's the policymakers who don't see what we see, so we have to make them see. And this is a success. It seems small, but it's actually really big, because it does mean that we can move for more things to be accessible. I put in here, and I'm happy to share these slides, some details on financial support that's available. The only thing I will say is that while people with work permits are eligible to apply for the disability tax credit, it's important to check with their lawyer if they're intending to apply for permanent residency, because it could be counted towards medical inadmissibility. And so I always say, like, do you want, like, let's think this through the long term, right? Like, let's think this whole thing through. So I just share that with you. School, so the BC Education Act says all children resident in BC can go to school, but different school districts have put in different barriers. Vancouver School Board says there's an access without fear policy, which means if parents don't have formal immigration status in Vancouver, the children can still be enrolled in school. Burnaby doesn't have an explicit policy, but doesn't ask for any immigration documents on registration. New West does, but then says you can confidentially apply. But ironically, Surrey, where most newcomer people live, they ask for the parents' immigration documents for enrolling in school, which is against the law. So I'm sharing this with you that there are and I had a similar discussion in Ontario. Don't worry, BC is not specific, but there are many ways that schools are not a place of safety. And as developmental pediatricians, so many opportunities to highlight and advocate. Transportation, as you know, thankfully, Handy Dart does not have any immigration requirements. Food and nutrition is really important. I would say that I think it's really important when we're admitting patients to ask directly if you eat halal and reassure them if they eat kosher halal that the food that they're getting is safe for them to eat, because sometimes they don't know if they're not literate, right? And they just won't eat. There's a number of, you can actually request a nutrition supplement through the Refugee Assistance Program. So I think that's something I wanted to talk about with you for our patients. And that there's other low cost food maps. But what I'm really excited about, there's a halal food bank that actually will distribute hampers. It's in Richmond, Surrey, Abbotsford, and Vancouver. And that might be something really beneficial for some of these families. Recreation, libraries are great. Strong Start is great. Infant Development Program does not need MSP, but yet on all of the application forms, they ask for a PHN and MSP number. So maybe they could think about that, because it could be a deterrent for people who don't have MSP. Kids Sport allows people to get grants to enroll in competitive sports. Variety Village is great. But I want to share with you, I mean, Dr. Smile may know about this organization. It has a great name, but they're called Smile Canada, and they're specifically to help immigrant children with disabilities in Canada. You can register families to be a Smile family. They now have this new, they have funding. So I had a child with spina bifida who needed who was an asylum seeker who needed a specialized stroller. They gave them a $10,000 grant. They now have a navigation program specifically for people who speak Urdu, Arabic, Farsi, Dari, or Somali, with intake forms in that language. And the only requirement is they have a disability, they're under 30, and they live in Canada. So wanted to share this with you because I think it could actually be a really nice resource for some of your kids. Okay, 2 minutes, real quick. You can actually build things with families, and you can publish them, and you can do scholarship. How fun. What fun research this is. Research can be fun. That's going to be my big takeaway. We developed, we did a co-design process with a group of 11 parents in 2 community centers in downtown Toronto of families who had children with developmental needs, to say what would be helpful for you. And through that process, we developed a multi-pronged intervention. They developed parent champions. They had a chat group for all their parents so they could set up play dates and share resources with each other. And then we built a toolkit with an accompanying workshop to actually train the parents and the people, their support team, their ECEs around them. That's what they said they wanted to be trained. And so we made this toolkit. It's, again, freely accessible. It's being used in all the early on centers in Toronto now. And we published it. So I just want to say that there's an example of something that you can do. I don't know if that QR code is still working. Hopefully it is.
Well, yeah.
Okay. If not, it's also on my lab website. So remember the patient I told you about, my very first patient. They have permanent residency now. He's in school full time. He's a teenager. And his parent is a co-PI on my CIHR funded RCT. And she's going to be co-presenting with me, hopefully at a workshop at an international conference. So this is what you can do with the families that you see. So that's my takeaway. I hope this was a really good, fast way. And I'm going to leave you with the question, So what else can we do? What do you think we can be doing here in BC to help improve care? Thank you.